All right, we'll get started on chapter 20, nursing care of patients with HIV disease and AIDS. So with the objectives, again, I'm going to skip over, let you read those on your own. Again, refer to the first page of the chapter. So HIV, the human immunodeficiency virus, was first reported to the CDC in 1981. One thing to think about when we talk about HIV is that 1 in 5 individuals are unaware of their infection status. So that means that we'll talk about there's a latency period from when someone could get infected until they begin to show signs or symptoms. So that can help make this statistic kind of come to life a little bit for you. Causes of exposure, again, everything according to your textbook. So men who have sex with men is 52%, heterosexual contact 28%, and injection drug use 8%. HIV is increasing in individuals over the age of 50. So I think that's something to really pay attention to in our nursing careers, because we may potentially see a higher occurrence of infections in those individuals that are in long-term care or those that are coming into the hospital, the baby boomer type of generation. So something kind of to think about there. Pathophysiology. Remember, this is that physiological process that's associated with the disease or injury, the patho. So HIV causes destruction of immune cells. HIV causes destruction of the immune cells. That's what's happening. There's 2 different strains. There's HIV-1, and that's a worldwide strain, or HIV-2, and that strain is primarily in West Africa. This chapter is going to focus on HIV strain number 1. It's the most common. It is possible to become infected with both strains 1 and 2. They're transmitted in the same way. They have the same symptoms. They're incurable and can progress to AIDS, but we are seeing some really neat research. When this textbook was written, it stated incurable, but we are seeing some really cool stuff that's coming out in clinical trials and studies in the last year or so. So keep that in mind too. All right. So HIV particle is taken into the human cell. And this is kind of background information related to patho. Reverse transcriptase is going to force that human cell to produce new DNA from viral RNA. HIV particles are going to spread into the lymphoid system. HIV is attracted to CD4 T lymphocytes, and we'll talk about those a lot related to what we're monitoring for counts. These CD4 T lymphocytes then begin to function abnormally, which causes more replication of the HIV virus. And as a result, overall, we get impairment of the immune system. So figure 20.2 is helpful to kind of walk you through this as well. Progression of an HIV infection. So infection to beginning of symptoms can take as long as 8 to 12 years. So there's that initial infection, then there's a clinical latency period, and this is a symptom-free period. And that's when we talk about going back to that 1 in 5 statistic that individuals can be spreading HIV without even knowing that they're infected. During this time, the CD4 T lymphocyte counts are decreasing. So that's really the only kind of thing that can give us some indication of what could be going on. The symptomatic stage is next, and this is when someone's considered HIV infected. They have symptoms of a weakened immune system, and if that it can develop into AIDS. And when that development into AIDS happens is when opportunistic infections occur or cancers. In your book on box 21, it's really helpful to kind of give you all the lists of different opportunistic infections that can take place. And these, by the CDC guidelines, are what have to be present in order for the AIDS diagnosis to happen. HIV prevention and education is so important in our nursing role. So the CDC recommends that we educate older school-age children that could be potentially sexually active, the general population, and older adults. Nurses are advocates for this, so really important that we understand that we have to educate, and seeing that higher incidence in the greater than 50 population may even bring about more education that we're responsible for, just to decrease transmissions that could happen, in long-term care facilities or things like that. HIV mode of transmission. So HIV infected blood or body fluids containing blood, semen, vaginal secretions, or breast milk are what are going to be the main modes of transmission for HIV. It's not spread casually. So when we hug someone, closed mouth kissing, shaking hands, sharing utensils, towels, etc., it's not going to be spread that way. It has to be spread through blood, semen, vaginal secretions, or breast milk. I want you to think a minute about how easily you could contract this in the healthcare setting, especially related to exposure to blood. So let's say that one of the most common things that I hear about and I've seen when I worked long-term care is taking AccuChecks without gloves on. So checking blood sugars without gloves on. So let's say you poke someone's skin and they're HIV infected, whether they know or not, and that blood gets into the dry cracks in your hands in the winter. That could be enough to be a blood transmission. Okay, so really think about that. Other things, dirty needle sticks, meaning that it's a needle that's already been in a patient. You didn't engage the safety, or you accidentally poked yourself. Really important to think about hand hygiene, personal protective equipment, standard precautions. No recapping of dirty needles. That's why a lot of hospital systems use these needleless systems or needle safety devices that engage. So when you're engaging those safeties on any needle, be very mindful that your hands, fingers don't get up anywhere near the needle that you're initiating that safety and letting the safety get up over the needle. HIV does not live very long outside the body. I don't have an actual time frame wrote down here, but that's kind of something important to think about too. It needs a portal of entry into the body, such as a tear in the mucous membranes, non-intact skin, access to the bloodstream or the lymphatic tissue. So if it just gets on our hands, we wash our hands, it doesn't get in through our skin or mucous membranes, then we're not going to get infected. The book mentions pre-exposure prophylaxis with ARV, which is called antiretroviral therapy. This is a really effective way to treat individuals at high risk of contracting HIV. HIV counseling and testing. So routine testing is done for ages 13 to 64, pregnant females, or after any sort of sexual assault. It's really important to think about confidentiality and individuals being anonymous related to testing. So sometimes permission is needed to release test results, especially when the partners are infected. So it's something that if you are working in the clinical setting or lab setting, that you will be trained on how you do that. Post-test counseling by trained personnel. So when someone gets their test results, it's really important that those results are explained well. They assist with informing sexual partners or drug needle sharers, and risk factor reduction and care options. So these are guidelines that are put out through the CDC, but in public health. So a lot of times what you'll find is when there is a positive finding, not only does the provider or nurse share those results with the patient, but then there's a lot of follow-up counseling that is done and connections that are made to help individuals through this difficult process of accepting that they have a diagnosis. HIV routes of transmission. So sexual, even greater risk if the HIV infected person has an STD. Because a lot of times what can happen is if the patient has an STD that has a lesion, then when during intercourse, that lesion can be where the HIV gets infects the other person. So really important as nurses, we teach safe sex practices, abstain or monogamous relationships where both individuals are tested. It can be parenteral transmission, and this is injecting drugs. About 1 in 1.8 million people have the chance of getting an HIV transmission from donated blood that is infected but has not yet had time to develop antibodies. So when someone signs a consent to receive blood, this in a formal context is listed on there that there is always a risk of HIV transmission, but it's low, okay? Very low. So again, it would only be that individual that has been infected with HIV, is unaware, their labs are unchanged, and those types of things. Perinatal transmission is transmission from mother to child. So women that are pregnant and they are HIV positive. So on all pregnant prenatal, they'll do HIV screening to see if mom has HIV. If she does, they're going to have her take antiretroviral or those ARV drugs to reduce the risk of transmission to the child. And then occupational transmission, the risk is rare if standard precautions are used, but this would be getting HIV in the workplace through a needle stick or blood from the patient. Post-exposure prophylaxis guidelines. So this is kind of some background information. Just realize that depending on the hospital or facility that you work at, this will be found in the policies and procedures for that institution. So just kind of some background guidance, but you're going to use the policy or procedure where you're working should this situation happen to you. It is an urgent medical condition if you're exposed to blood or body fluids, making sure that you wash the exposure site with soap and water. Mucous membranes need to be flushed with water. Begin this whole process right away so you don't, have an exposure, go home, think about it, realize maybe you should tell somebody, you just tell somebody right away. Consider your risk factors, test the source. So if the individual was a patient and they are notified of what happened and are willing to consent to be tested, but sometimes they don't always consent. So when the patient won't consent, then oftentimes the employee is treated as if they are infected so that they receive all the treatment they would need, not knowing if the patient was infected or not. Treatment can be up to 4 weeks. It really depends on, other blood and body fluid things, how long that testing and treatment can take place. The one thing, just going back, that I want to say from that last slide is, as nurses, not to scare you, but the best method is almost, and this doesn't even really relate directly to HIV, but I want you to always think about everybody could potentially be infected. So not to let you glove up and never touch someone's skin. Obviously that's extreme and that wouldn't happen given, the circumstances. But I want you to think about protecting yourself from everybody, because we don't know what potentially any of our patients could have. So good standard precautions, good use of personal protective equipment, those types of things. HIV early signs and symptoms. When we look at this list, this is not going to tell us, oh, this person has HIV because they have fatigue. Think of all the things we could have that make us tired. So fatigue, headache, fever, lymphadenopathy, which is the lymph nodes get abnormal in size, number, and consistency. So we have a lot of lymph nodes, all throughout our facial body, jaw, behind and in front of our ear, going down our neck. But really important, if we look at this individual where that arrow is, you see that enlarged lymph node. We'd find that through palpation. Diarrhea, sore throat. With HIV early signs, at first there's no symptoms. Or there's acute retroviral symptoms usually develop 6 to 12 weeks after HIV transmission and can last a few days to weeks. So normally individual gets infected, they feel fine, 6 to 12 weeks later, then they start to develop some of these symptoms that can last a few days to weeks at a time. But as we said, these are symptoms that could be associated with a lot of other things, so individuals may not realize potentially what's going on. HIV late signs and symptoms, things like shortness of breath, weight loss, night sweats, persistent diarrhea, or oral or vaginal candidiasis, which are yeast infections. Remember, if it was oral, the tongue would be kind of white coated. If it's vaginal, then the female would have a white kind of gunky cottage cheese type discharge. Dry skin or skin lesions, peripheral neuropathy, so that's that loss of nerve sensations in our fingers, toes, shingles, seizures, and dementia. The final stage of HIV infection is called acquired immunodeficiency syndrome, or AIDS, the actual diagnoses. To have an actual AIDS diagnosis, somebody has to have a CD4 T lymphocyte count below 200 or an opportunistic infection or disease present as defined by the CDC. And again, there's that table at the beginning of this chapter that's going to tell you what those opportunistic infections are. Complications, AIDS wasting syndrome. So this is involuntary weight loss that's greater than 10% of body weight, chronic weakness or fever, or chronic diarrhea, and it's going to last more than 30 days. Okay, so factors that are going to contribute to this, somebody that has AIDS wasting syndrome, they may have decreased appetite, oral lesions, which is going to make it very uncomfortable for them to eat or drink, altered metabolism, malabsorption, GI infections, diarrhea, medication side effects, and cognitive impairments. So this is something we don't always think about, but AIDS wasting syndrome can definitely happen. AIDS dementia complex. So for individuals that have AIDS, they can definitely develop dementia. Memory impairment, personality changes, hallucinations, loss of balance, slow responses, and with all of these things, remember, safety is very important to us as nurses. So these are patients that become very high fall risk, very high risk for harm to themselves through their actions because they may not be aware that what they're doing is not safe. There's a great video that's linked in your Brightspace related to the AIDS dementia complex that I encourage you to watch. Other complications, opportunistic infections or cancer. Let's see. I'm just looking here. We do this a lot of times as group work in the class. So just looking for just a second. Opportunistic infection. So what I do in class and what I am going to do here in the PowerPoint is just really encourage you to look these things up on your own, just to have a very general understanding of what they are. Okay. The Kaposi sarcoma is what's illustrated here in the picture. This is a type of cancer that can form in the lining of blood and lymph vessels. It usually appears as painless purple spots on the legs, feet, and the face. So some of the complications, if you're not familiar, I would just have you look these up just so you know. Diagnoses: HIV antibody tests, those CBC to get a lymphocyte count, definitely that CD4, it can be a CD8 as well, T lymphocyte count, but we have to have that, remember, because in the AIDS diagnoses, it's either that CD4 T lymphocyte count less than 200 or one of those opportunistic infections. Viral load testing or genotyping. HIV screening is recommended for anyone from 15 to 65 years of age at least one time. Okay, so HIV testing is done using finger stick blood, oral swabs, or serum specimens. Remembering that it takes at least 3 weeks to 3 months or longer in some cases for those antibodies to be formed. So early detection HIV tests are available as soon as 1 week after potential exposure. But if you think about somebody that maybe has a lot of partners and potentially how they could become exposed to HIV and how many people they could pass that along to before they even realized that they themselves were carrying that. HIV antibody test, it's called an ELISA assay that's done, and that's repeated. There's also a Western blot test that can be done. We're not going to focus a lot on these. This is kind of some background information. Those CBC lymphocyte counts, if somebody is HIV susceptible to leukemia, or leukopenia, lymphopenia, anemia, and thrombocytopenia. So we're looking at their risk for bleeding, their risk for low red blood cells, those types of things. We already talked about the CD4 T lymphocyte counts. Usually these are done kind of in 3-month intervals to kind of see if numbers are trending down to support the diagnoses. Viral load testing measures the HIV in the RNA plasma, and genotyping measures resistance to currently available ARV treatments, those antiretroviral therapy treatments. General testing can also be done to determine if somebody has syphilis, hepatitis A, B, or C, or liver chemistry panels. Therapeutic interventions, there is no cure. So clients begin the HAART, highly active antiretroviral therapy treatment. The goal of therapy is to prevent or delay those opportunistic diseases. So at this time, when this book was created, everything we're going to go along with is that there is no cure, no definitive treatment, but we're trying to help individuals prevent or delay those opportunistic infections that would change the HIV diagnosis to an AIDS diagnosis. In your book, Table 20.4 is helpful to demonstrate this as well. Therapeutic interventions or antiretroviral therapy is early aggressive treatment. Multiple drug therapy can be done, so 3 drugs in at least 2 classes of treatment categories. This is going to reduce the viral load to undetectable levels and prolong individuals' chance of survival. Again, in your textbook, Table 20.5 is helpful with this. I'm not going to have you memorize medications related to HIV because they're changing all the time. And quite honestly, you're not going to come across them every day in practice. So when I'm working and these medications come up, I have to look them up. So they're not common enough that at this point, I'm not going to have you memorize everything related to HIV medications. Nursing diagnosis and interventions, ineffective protection. So hand hygiene and bathing, avoid sharing grooming items. So that would be things such as razors, or anything that could have blood on it. Washing toothbrushes, cleaning dishes, report infection symptoms. Interventions related to pain, identifying the cause of pain for these individuals, giving pain medication, complementary therapy such as heat or cold, using massage or positioning. And then imbalanced nutrition, less than body requirements. Remember, we talked about the AIDS wasting syndrome, but also these individuals are going to a lot of times be pretty nauseous. So there's Zofran, which is a medication for nausea, that I put a little picture here to just kind of remind you, but identify interfering factors, making sure that we're weighing the individual, because that's how we're going to monitor if the weight loss is occurring, monitoring caloric intake, consulting dietary, small frequent meals, and antiemetics, which are the medications that are going to help with the nausea and vomiting. All right, that's everything for chapter 20. This chapter is really helpful when you read your book and compare it to the PowerPoint. So the PowerPoint just kind of builds and pulls out some of the main ideas, and the chapter really has all kind of the background information that's going to glue everything together. So make sure that you read your chapter, you pause, re-listen to the PowerPoint, and definitely, take notes and apply the information. All right, let me know if you have any questions. Thank you.